The topic given to me today is to talk about viral hepatitis A and E. As you know, these are the important viral hepatitis infections which we see day and day in our routine practice. Hepatitis A and E. So I will discuss more about the historical perspective, then briefly about the virology, the relevant virology of hepatitis A and epidemiology, clinical features, special scenarios, diagnosis, treatment, and the vaccination and the approaches. So acute viral hepatitis actually is an infectious illness which was described as early as 8th century, and there were multiple outbreaks throughout the history, especially in the 18th and 19th century, and in early 2000s, 20th century. Empirically, infectious hepatitis was described into two separate entities, either hepatitis A, which was the first hepatitis virus to be described, and then the serum hepatitis, which was later described as hepatitis B. So in 70s, finally we have the hepatitis A and hepatitis B were finally discovered, and still in 70s there was no hepatitis C virus or hepatitis E virus which was discovered. So all these other the hepatic like illnesses were attributed to non-A, non-B post transfusion or infective hepatitis. So as you know, there was a flooding of Yamuna in 1955, and there was contamination of the water supplies, and there were a lot of icteric illnesses were noted. Around 2.3% of the population in Delhi was found to have an icteric illness in the sample of around 29,000 person, and they were noted that the young adults were having the highest disease rate, and most of these illnesses, acute icteric illnesses, were self-limiting except in the pregnant woman where there was a high case fatality rate. So this was initially reported in New England Journal of Medicine 1953, and the first time the hepatitis E virus was described by Dr. M.S. Khuru from Kashmir, and there was an outbreak of acute viral hepatitis in Kashmir in around 275 cases between 78 to 79, and it infected mainly the young individuals 11 to 40 years of age, and there was common water source, and some of them developed fulminant hepatic failure, and some mortality were noted, and all viral markers for hepatitis A and E which were there at that time were negative. So it was first suspected to have some non-A, non-B, some hepatic illness, which was later on found to be hepatitis E by Dr. Mikhail Balian. So this is how the hepatitis E virus evolved, and there were many epidemics before, and it was attributed to non-A, non-B viral hepatitis, but it was actually hepatitis E. So he finally discovered the hepatitis E virus as a cause of acute viral hepatitis in the stool samples, and they found the 27 to 30 nanometers spherical viral-like particles, and which aggregated with the convalescent serum from the patient with non-A, non-B hepatitis. So he self-inoculated the virus, the stool infected the infected stool from the stool from the infected individual, the hepatic patient, and then he got the acute viral hepatitis, and then uh, this this virus get aggregated with the convalescent sera, and thereby diagnosis of hepatitis E was found. So it is the only member of the genus Hepiviridae in the family Hepiviridae, and there were two species, mammalian and avian, and it is small non-enveloped single-stranded viral RNA, so which is around 27 to 34 nanometers, and it is the genome is around 7,200 kilo base pairs with short non-coding segment at both 5' and 3' position. As you can see here, this is the genome of the hepatitis E virus. There is a non-coding region and the coding region, and there are three open reading fragments: ORF1, ORF2, and ORF3, as you can see here in this figure. The ORF1 is mainly responsible for the non-structural proteins like and have various enzymatic functions like heliase, protease, RNA polymerase, or the methyl transferase, etc. ORF2 is important because it codes the structural protein, and it is responsible for the neutralizing antibodies against the virus. So all the vaccination, all the neutralizing, the immune response is against the ORF2 of hepatitis E virus. So it is mainly there are four genotypes. There are some variations in the hepatitis E virus in globally, and the in India you can see the most common the genotype is genotype 1, and sometimes it is also genotype 4. But in the West and the European countries and the America, what you can see major genotype is genotype 3. So you can see here in the Indian subcontinent, the most common cause hepatitis E genotype is genotype 1, followed by genotype 4. So the most common route of transmission, so it is acute self-limiting hepatic illness and most commonly transmitted by the fecal route, mainly by the contaminated drinking water. And the other routes may be foodborne transmission. Some of the cases have shown the transfusion through the infected blood products, but this is rare in the current scenario. And there have been reported transmission from the mother to child transmission is noted, but this is all very rare scenarios, and it is mostly related to the consumption of the fecally transmitted drinking water, and sometimes it may occur in the endemic and the epidemic forms with large number of individuals infected, and there may be outbreaks which may be unimodal or prolonged multi-peak epidemics which may last up to more than 4 years. And frequently you can see the acute viral hepatitis is seen during the rainy seasons, during the floods, during the moisture in the environment, or when there is a high chance of contamination of the water with the viral hepatitis E. So it also sometimes occur in the hot, dry summer where there may be less of water available for drinking, so there may be hygiene issues. So other scenarios may be urban areas with leaking water supply, and apparently there is a no person to person transmission, unlike the hepatitis A where there is a high secondary attack rate in the family. Lot of person in the individual family get infected same time from one person to other, but in the hepatitis E there is no person to person transmission, and the secondary attack, the overall symptomatic attack rate is 25%. The most of the around one-fourth of the individuals who are infected with HIV are symptomatic. The asymptomatic infections are more common in the children and those who in the pediatric age group, but it is more symptomatic infections are more common in the adults, especially in the pregnant women. The most of them are symptomatic, and they tend to develop the more severe disease in form of liver failure or other complications. So as I said, the disease rate is highest among the young adults and the low disease rate in children due to asymptomatic infections. And the male is more commonly infected as compared to female because of the higher risk of consuming the contaminated water. So the special scenario is the pregnancy and hepatitis E. There is high proportion of AVHE due to hepatitis in pregnant women as compared to the other acute viral hepatitis. So B is more common, E is more common than the hepatitis B or A in pregnant women, and it is a higher incidence of fulminant hepatic failure uh, in pregnant women with HIV. In fact, the HIV is the most common cause of acute liver failure in the pregnant woman, and it is associated with the poor maternal and the fecal outcome. So the first field study was done by Dr. Kuru in around 1980 or 79 to 80. Then this was a prospective where during the epidemic of the non-A non-B hepatitis, which I discussed earlier, and they divided these individuals into three groups: pregnant women, non-pregnant women of childbearing age, or the men. And they found that those who are pregnant women have the higher incidence of developing acute viral hepatitis, around 17%, and the fulminant hepatic failure was more common in the pregnant woman as compared to the men and the non-pregnant women. So there is a peculiar susceptibility of pregnant women to develop the HIV infection, and the incidence is higher in the third trimester as compared to the second and first trimester, and it may have the impact on the fetal and the maternal outcome. But the more recent study from AIMS by Dr. Vikram Bhatia and colleagues have shown that the ALF in the reproductive age group they have studied, and they found that the pregnant women, although they have the higher incidence of HEB related ALF, but the mortality, irrespective of the cause of, irrespective of the type of patient, is similar. So mortality was similar in pregnant women, non-pregnant women as well as men. So they recommended that the outcome of HEV ALF is independent of the sex and the pregnancy status of the patient, and the mortality in HEV ALF versus non-HEV ALF in pregnant women was similar, and there was the outcome was unrelated to sex, contraindicated the contrast. There was no result as compared to the previous other studies. So as you can see here, the prevalence of HEV failure is quite high, in the developing countries. Like you can see here, in the Bangladesh, the 63% of the fulminant hepatic failure are due to HEV. In India, 41%. Pregnant women, almost all viral hepatitis E is the most common cause, almost 94%, and other series around 75%. So these are the scenario, because HEV is important because it has various varied spectrum in different individuals. So the clinical features in endemic countries, it is a self-limiting illness. The patient present with acute rectal hepatitis, they develop jaundice, which is indistinguishable to other hepatotrophic viruses like HAV, and it lasts for few weeks, which improves spontaneously. Incubation period is 2 to 8 weeks. Prodrome is flu-like myalgia, arthralgia, weakness, vomiting, which precedes the onset of jaundice, and jaundice sometimes may have and darkening of urine. So, despite the prolonged cholestasis, rarely it presents as the fulminant hepatic failure, and especially in the pregnant woman. And there is high incidence of asymptomatic or inapparent HEV infection is also there. So sometimes in patients who have underlying cirrhosis or chronic liver disease, the HEV superinfection may lead to worsening of liver disease, development of ascites, and other complications of cirrhosis, organ failure. So these are considered as acute and chronic liver failure. So HEV in Indian setting is an important acute precipitating factor leading to ACLF in a patient with cirrhosis, and this is associated with the very high risk of poor outcome. So initial studies have shown that the HEV is responsible for decompensation in endemic areas with high mortality in these patients. So what we not see here in India is chronic hepatitis E, but it is common in those with genotype 3 infection, especially in the Western population. And this is defined as the persistence of the HEV RNA in the serum or stool for more than 3 to 6 months. And it is mainly seen in the immunosuppressed individuals, the post-transplant patients, the retro HIV patients, patients who are on chemotherapy, hematological malignancies, solid organ transplant. So all these individuals are in these patients where there is persistent hepatitis for 3 to 6 months. So one should do a HEV RNA to look for any chronic HEV infection. So, but in India, it is always more or less genotype 1, so which is not associated with any chronicity. So you can see here the IgM antibody is not reliable in chronic HEV, but HEV RNA is the most important. So diagnosis is done of the hepatitis E infection by doing the ELISA based the nucleic acid, or indirectly by the immune response to the host in form of the antibodies. So you can see here the initial during the incubation period and the late incubation period or prodromal period, there is a presence of the hepatitis E virus in the stool or in the blood. So which can be detected by the HEV RNA positivity in the blood or the feces. It lasts up to 4 to 5 to 6 weeks. Then after the onset of the jaundice, then these patients develop there is severe transaminitis, which resolves. Jaundice sometimes also resolves in most of the cases. And there is a development of the chronic antibodies like the IgG, HEV antibodies, which last for a prolonged period of the time. So detection of the HEV RNA in the sample is important in some of the cases, but in routine cases, the antibody tested with IgM anti-HEV is sufficient, and the HEV RNA is undetectable in blood after 3 weeks of the onset of symptoms. So early diagnosis by HEV RNA is important in some of the cases. The antibody may last up to 12 weeks or so, the IgM antibodies. So the treatment, there is no major treatment, only ways to avoid any hepatotoxic drugs, maintain the hydration, and and nutrition, and generally this is a self-limiting illness, do not need any specific therapy. And in patient with chronic HEV infection, we need some of the cases the PEG interferon, ribavirin, and because the early treatment of the chronic HEV infection is important because these patients are rapid fibrosers and may develop cirrhosis within 3 years of infection. So some of the cases where there is very severe hepatitis, very high jaundice, some of the studies have used ribavirin in these patients have shown the good result in terms of the resolution of the jaundice and the good outcome. But these are uncontrolled studies, and we do not recommend the use of ribavirin or any other antivirals in acute hepatitis E settings. So vaccination is important to prevent the infection, but it is not available as yet. The basis is to provide the once there is a recovery, there is a protective and immunity, neutralizing antibodies, T cell response, CD8 and CD4, and against the ORF2 there is a the antibodies will aggregate and lead to the protection. So the first vaccine, the last trial was done in the China, the phase 3 trial of around 1 lakh individuals. The recombinant HEV vaccine derived from the protein encoded by the ORF2 of the HEV genotype 1 virus, and they were found to be highly effective in protecting the infection, and it is also safe in the pregnant woman, and it protects against all of the genotypes 1 and 4 especially, and it is approved in routine use in China in December 2011, but in India it is not routinely used, the HEV vaccination, and not also available. So to conclude, hepatitis E, only genotype 1 in India. The mostly it is waterborne infection, and HEV constitute about the 30% of the acute viral hepatitis in India. Higher proportion in pregnant women with high risk of acute liver failure. Generally, it is a benign course. Unlike hepatitis A, it is a low secondary attack rate. The mortality is very low in the general population, and symptomatic HEV infection generally between 15 to 40 years, and children are mostly asymptomatic. The seroprevalence begin to rise in late adolescence and peak in second to third decade of life. So most of the children are by that time may be infected by that time. So most of them had the asymptomatic infections. So in India it is around 25 to 50% seroprevalence at the age of 40, and it is one of the most common cause of acute liver failure, acute and chronic liver failure, barring the alcohol use. Only supportive management is needed. Severe cases may require the ribavirin therapy. Some studies are there. In chronic HEV infection, in immunosuppressed individuals, it occurs only in genotype 3, may lead to early cirrhosis. Ribavirin and interferon may rescue these patients, and vaccination is important, but it is not yet licensed in India for general use. So now the second similar virus is hepatitis A virus. There is nothing special about the hepatitis A virus. The route of transmission, the clinical features, and the treatment, and everything is same. It is also transmitted by the close personal contacts, contaminated food and water, sometimes in immunosuppressed individuals, by IV drugs use, transfusion, meal-to-meal sex. These are the uncommon routes of HIV transmission. And India is a high prevalence area. The most of the adult individuals have the positive antibodies to HIV due to past infections. And like it is very common in the highly endemic areas where the infection generally occur in the early childhood. And the important thing is there is a person-to-person transmission with highly secondary attack rate, highly familial transmissions in HIV as compared to HE. And in the low endemic areas or the very low endemic areas, especially in the developed countries, you can see the disease rate is low, and the peak infection generally occurs in the adulthood and the young adults. And it is generally seen in the travelers, and outbreaks are less common in the developed countries as compared to the developing countries. The incubation period is around 2 to 6 weeks, and jaundice is generally seen in those who are adults more than 14 years of age. Around 80% develop icteric hepatitis. In less than 6 years, almost all are asymptomatic, which are barely detectable clinically. And some of them develop complications like fulminant liver failure. Sometimes there may be cholestatic hepatitis, relapsing hepatitis. There is no chronic HIV infection. So mostly the onset is abrupt, duration is 1 to 2 weeks. Sometimes there may be prolonged cholestasis which may last up to some months, but less than 6 months, and rarely fatal despite the presence of prolonged cholestasis. As I said earlier, the children are generally asymptomatic, 5 to 10% have jaundice, and adults are generally symptomatic. Most of them have jaundice with a lot of prodromal symptoms, lot of weakness, lot of weight loss, but generally it is self-resolving. And greatest infectivity is 2 weeks before the onset of jaundice. So the viral shedding is mainly late incubation and the prodromal period, and diminished rapidly after the onset of jaundice. So the most of the familial transmission occurs before they develop jaundice during the prodromal period or the late incubation period. So there is a phenomenon like relapsing hepatitis A, the recurrent hepatitis secondary to primary infection. So some of the patients may have the multiple peaks of the infection of the jaundice or the icteric illness. So the severity of the symptoms and the biochemical abnormalities during week tend to be same as observed in the initial illness, except with the greater cholestasis. So it does not matter whether it is relapsing or it is prolonged cholestasis, the outcome hardly is different, and generally it resolves on its own. So lab diagnosis is generally by the IgM anti-HAV antibodies, and for research settings, sometimes the RT-PCR may be done, but it is generally not useful clinically. There is no treatment, only self-limiting illness. General measures like maintain hydration, nutrition, and prevention of infection, and is important. The prognosis, as I said earlier, it is a benign course, and mortality is very limited, except in those patients who have cirrhosis or the elderly with immunosuppression. They have high risk of developing acute liver failure. Prevention is by immunoglobulin. uh, so immunoglobulin, there are specific indications, and I will come to it later. The prevention is post pre-exposure prophylaxis. The indications are patients, especially these are the people planning to travel to endemic areas, and the high risk individuals like men who have sex with men, illicit drug abuser, patient with cirrhosis, patient with receiving multiple blood products like clotting factor concentrates, hemophilia. So these patients require the pre-exposure prophylaxis with HIV vaccination. So what vaccine is available? It is HIV either in combination with hepatitis B or alone. So you have this 2-dose vaccine of hepatitis A, or combined 3-dose vaccine with hepatitis A and hepatitis B. So prevention is by immunization and sanitation, education, good personal hygiene, safe food, avoid outside vendor foods, and wash your hands before food, and avoid the ice and outside water. Um, maintain hygiene. And the standard immunoglobulin prophylaxis is 90% effective if it is given within the 2 weeks of exposure. And the immunization 2 weeks prior eliminate the need of immunoglobulins. Indication of the IV, the immunoglobulins are the close personal contacts, the daycare center outbreaks, the fellow food handlers, the patterns, etc. So these are the individuals where there is high risk of transmission from one individual to other in the close settings, like in the daycare, like in the uh, 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 like in some like the fellow food handler. So in these scenarios, the immunoprophylaxis may be required if someone one is infected to prevent the infection. So there is high potential of outbreaks in the food workers. Verify the diagnosis, evaluate the food-related duties, types of food preparation methods. Wearing gloves reduces the risk, etc. So this is in general about what is hepatitis A, hepatitis E. I discussed about the virus, then the clinical feature, the diagnosis, the treatment options, and how to approach these patients. Thank you for the attention.